right, welcome everybody. So my name is Samantha Bellinger, and I'm the program specialist with the Perinatal Quality Collaborative of Vermont, or the PQCVT, which falls under the umbrella of VCHIP. I'm happy to welcome you all to this particular installment of our webinar series. The title of today's talk is Protection Against RSV Infection, Pregnancy or Neonatal Protection Strategies. So before going into the presentation itself, I wanted to go over a few housekeeping items. We will be monitoring the chat feature throughout the presentation, so feel free to use that chat to post your questions at any time. And also please know that if we don't get to your question right away, that we will address all the questions at the end during the Q&A portion of the meeting. In addition to the chat function, if you would like, you're also welcome to use the raise hand option. That'll allow us to call on you, and from there you can unmute. And speaking of unmuting, you should have all been muted upon entry. We ask that you stay on mute during the presentation just to minimize unintended distractions. If you wish to verbally ask your question, you're welcome to unmute and ask it. So this webinar has automated captions. If you would like to activate those, go to your navigation bar and click Show Captions. Depending on your settings, you might have to go to the hidden space that is like the 3 ellipses, and use that to find the captions option. So for an evaluation, we're going to be sharing a short survey at the end of the webinar. You'll also receive that link in an email that should be coming out tomorrow as a follow-up. You should also be receiving a recording in that link or in that email as well. And finally, I'd be remiss not to mention that we have a PQC listserv. So if you're not already on that and you're interested in joining, please reach out to us via email, which is vchip.pqcvt@med.uvm.edu. It's on the screen here as well. And see, I think that's it for housekeeping. My understanding is that our speakers don't have any disclosures, but this webinar was put together as a collaborative effort of VCHIP, the PQC, the Med School, UVM Medical Center, and the Vermont Department of Health. And during today's presentation, we are going to be hearing from 4 different speakers. So they are Dr. Ben Lee from Pediatric Infectious Disease, who will be reviewing RSV prevalence and newborn protection. Also from Dr. Marge Meyer of Maternal Fetal Medicine, who will be reviewing protections with the maternal vaccine. Dr. Whitney Barkoff of Neonatology, who is going to be reviewing considerations around high-risk babies. And Katie Mahiran, who is with the Vermont Department of Health, who is going to be reviewing the statewide rollout and how to obtain products for administration. And so at this point, I will be turning it over to Dr. Lee. And you can just ask me to advance slides.
All right, thanks everybody. So yeah, I just will talk briefly about the burden of RSV and the new monoclonal antibody. So next slide, please. So I just wanted to make sure we are able to sort of avoid recency bias when thinking about RSV, because as we all have experienced, the last 2 seasons have been very unusual as far as the typical epidemiology for RSV. So this is just an epi curve that plots all the most recent 5 seasons together. And what we normally expect to see is a peak of RSV cases peaking in December and January. You can see that cluster quite clearly. Those are all pre-COVID. But then starting in 2021 and then last year's season 2022, we can see that those peaks shifted rather early. And now, those were anomalies, and every indication is that we're now settling back towards a typical pattern where we expect to see RSV peaking in December through January in most regions. Next slide, please. And this shows the same thing. Sorry, it may have come out a little bit small, but just focusing not on the entire country, but just those regions in the Northeast, so regions 1 and 2. And basically, they just show the same thing in tabular form. So the region 1, which is where we are, every year up until 2021, we would see a peak in December. However, the previous 2 years, we saw those come earlier. But as we go on into this 2023-2024 season, we definitely see the return of sort of pre-COVID epidemiology. Next slide, please. And so here's where we are as far as state trends. So I'll just tell you the last bar on the right is October of this year, and the large peak in the middle is November of last year. So last year we were already at, by November 1st, we basically were already at our peak or close to it. But here we can see that the number of positive tests is still really not taken off yet. Next slide. And across the country, what we see is starting in late September and moving into October at the very right of the chart, we can see cases starting to tick up. And that's with the return of RSV activity, mainly in southern states, which is, again, what we normally expect to see. And that is the typical pattern. So we haven't quite gotten into the thick of the season yet here, which is a vast difference from what we've seen the past couple of seasons. Next slide, please. So just really briefly, again, just to reiterate the burden of illness due to RSV, 50,000 to 80,000 hospitalizations a year with hundreds of deaths in young children. It remains the leading cause of hospitalization among infants, with rates of hospitalization being threefold higher in preterm infants born at less than 30 weeks of life. And the same population has much higher rates of ICU admission, not surprisingly. And now we know that there already is, for the highest risk infants, one option for infant protection, which is Synagis. However, because of pretty modest efficacy, the population that is eligible for Synagis has grown increasingly small ever since it was first introduced, such that now only about 5% of US infants are eligible at very high cost and requiring monthly dosing. So clearly, better alternatives were needed. Next slide. So I wanted to touch briefly on now one of these new options, which is nirsevimab, which goes under the brand name Beyfortus. And I just wanted to highlight why this product actually is different from Synagis and how. So Beyfortus, it's a very highly potent fully human monoclonal antibody. So just a little pet peeve of mine coming from the infectious disease world. I'd just like to remind folks, this is not a vaccine, even though we sort of talk about it in the same way that we would talk about vaccines. This is a monoclonal antibody that provides passive immunity. So it's an immunization, but not a vaccine. And so sorry to split hairs there, but I just couldn't avoid, I just couldn't help myself. The reason why this is different from Synagis is it's very highly potent. What we have here in the figure, in the middle, there's a figure that's titled Prefusion RSVF. What that is, it is a protein that protrudes out from the virus before it is attached to host cells. And what we see is at the very tip of that protein, in red, is a region that has the highest neutralizing potency epitopes. So what that means is if you can block that region with an antibody, that is going to give you by far your most potent protection. And so that is exactly what Beyfortus does, is it's an antibody that blocks that viral protein right at that tip and prevents it from springing into what's known as the post-fusion conformation, which is on the right. You can think of it like an umbrella. When you push the button of an umbrella, it just sort of all springs out. The same thing happens with RSV. When the virus attaches itself to a host cell, this protein springs out, and importantly, that region then disappears. What scientists have faced in the past is when trying to identify antibodies against RSV, the preferred conformation is in that post-fusion state. So they couldn't find antibodies that could actually target that really highly potent tip region. And with lots of different advances that I won't get into, this has now finally been accomplished. And this is the difference between Beyfortus and Synagis. And this is also the basis for the for the new adult vaccines as well, is inducing antibodies that actually target that pre-fusion conformation that could then potentially prevent the virus from causing an infection. Next slide, please. Okay. And so, as I just mentioned, Beyfortus or nirsevimab targets the tip. Palivizumab targets the side of the protein, which, as you can see, is considered a very poorly neutralizing region. So the antibody will bind, but it doesn't do much to actually prevent the virus from entering cells, which is the key difference between Synagis and Beyfortus. Next slide, please. Okay. These are slides that just show there have been a couple of clinical trials that have demonstrated efficacy. The first was a phase 2b study in preterm infants. And I'm not sure if you can see the figures well, but what this shows is you can see a clear difference between placebo recipients and nirsevimab recipients in terms of their risk for getting RSV through the first 5 months after dosing. Next slide, please. That was in preterm infants. There was a different trial known as the Melody trial, which was in late preterm and term infants. And what we can see here is clear demonstration of efficacy against medically attended RSV, RSV hospitalization, and severe medically attended RSV. Next slide. And this is just a table I put together summarizing the evidence. So the two trials that I just showed data for are listed. And the CDC did a pooled analysis where they took all the data from both of those trials and pooled them together. And if you look at all comers, the antibody is about 80% effective against protecting both against medically attended RSV and against RSV-associated hospitalization. Importantly, in this pooled analysis, they actually, thank you. They only included infants who got the recommended dose. So in the initial phase 2b trial in preterm infants, there actually were some children who got a lower dose than what is currently recommended. So the CDC analysis only looked at kids who got the currently recommended dose, and we see about 80% efficacy. Next slide, please. And finally, there was another slide looking at it in comparison to Synagis in preterm infants, primarily for safety. So we don't really have good efficacy data for this, but basically what we find is that it is safe to use, and PK studies show that we get similar antibody levels in this population as what we saw in the Melody trial. So we can extrapolate efficacy based on antibody levels. So there's really scientifically no reason to expect that that this product would not be equally efficacious in that specific population. Next slide. And then finally, there was also a parallel trial that was conducted in Europe, which I don't believe was included in the FDA reviews, at least formally. But there was another trial called Harmony, which was basically the same type of trial, but conducted in Europe. And that really nicely replicates the findings that I presented. They're about 80% effective against RSV hospitalization for infants in their first season. Next slide. Okay, and that's it for me. Thanks.
All right, Marge, you are up.
Thanks, and feel free to put things in the chat. I have my eye on that. So now I'm just going to talk about, since the obstetricians are probably going to have the very first conversation with people about this. I think it's going to be important that we kind of understand the whole framework. So next slide. So remember that the reason that Tdap vaccine works is because we give moms a big boast of pertussis vaccine at 28 weeks. They make more pertussis antibodies. Those antibodies cross the placenta. It takes them a little bit of time. First, mom's got to make the antibodies. Then they have to get across the third trimester. Those IgGs will cross over. And they get into, this is to remind you of your physiology, into the intervillous space. This is the maternal blood. Here are the villi, remember, that are getting bathed by the maternal blood. These little IgG molecules can traverse that cytotrophoblast and get into the fetal blood here. And this is this passive immunization of the baby against pertussis. And this has dropped the rate of neonatal pertussis till babies can get vaccinated by about 50%. And this is how, this is just a blow up of how these IgG molecules get across the fetal endothelial cells into the fetal blood. So I think it is important to remember, again, conceptually, as Ben said, these are both passive immunization strategies that mean that you're taking antibody, providing that to the baby, and then the baby clears those antibodies and then they're susceptible again. But ideally, the course of the disease will be better. So this, the new Abrysvo vaccine, is the RSV vaccine that has now been FDA approved for use in pregnancy at 32 weeks to 36 weeks, so that mom can get that antibody boost so that those antibodies can cross over into the placenta and passively immunize the baby. So next slide. So this is the paper that just demonstrated that its effectiveness, and Ben just talked to you about that vaccine efficacy. For the maternal trial, what they looked at it as the primary endpoint was severe disease within 90 days after birth. And it was about, again, 80% effective. You can see everything is hovering around this 80% effective rate. There were there was another outcome of just RSV in general that was slightly improved, but not statistically significant. But both for 90 and 180 days after birth, there was significant efficacy. And I do want to call out, it's not a very highly prevalent disease. This is the cumulative incidence of severe RSV in neonates. And we're still only talking, even in the placebo group, maybe 2% or so. Next slide. So, oh yeah, I forgot. I thought I took this out. This is just to show you that pertussis vaccine works. And so we have every reason to think, and this obviously works in a similar way. And look at what we did with whooping cough. This goes back to 1922. Tdap was super helpful, but now we, this little blip, I think, were people not getting vaccinated in this period of time. Anyway, this is just the pertussis rate. You can see how it's dropped off when we started vaccinating moms. Next slide. So I have this slide, and then the next slide are handouts that I've emailed to most of you. If you don't have them, we can send them out. You can format them in your institutional colors, however you like. But this is actually information. This is kind of dense. So it's for you to have that conversation with patients as you're trying to decide for the maternal vaccine versus the baby vaccine. This is just a summary of what Ben just talked about. This is just basically the summary and the timing, so that these are your talking points for when you're talking to parents. Again, it's given once between 32 and 36 weeks. And we're going to talk about where they get it with Katie at the end. So the next slide. And so this is the one you can give your patients. It's less wordy so that they can just get a sense of the big picture of pregnancy versus newborn vaccine. And the fact that they're both pretty effective. As Ben and I talked about, the neonatal one might be just a titch longer and maybe a titch more effective, but you're going to see why that's probably less an issue with the next slide. That I think is why we as obstetricians need to really have conversations with our patients to encourage maternal vaccination. Not surprisingly, with now recommending neonatal vaccine, neonatal monoclonal antibody for all neonates, there's a concern that there's going to be a limited availability for the neonatal product. As you know, right, moms are having to get it at 32 weeks. I would not be certain that their pediatrician will have the neonatal product in the office 8 to 10 weeks later, unless their baby's at particularly high risk. So we might want to, because of the relatively equivalent efficacy, we might want to really encourage the mom use of the vaccine. So next slide. And so now I'm going to turn it over to Whitney.
Thanks so much, Marge. Thank you. And I am happy to have the opportunity to speak a little bit about considerations for RSV protection for our highest risk babies. It is great that we have Beyfortus and this maternal vaccine available, but due to the nursivimab shortage, just want to pay particular attention to our highest risk infants and just make sure that they're not getting lost in the shuffle with some of these other issues. And I know Katie is going to talk more about the shortages and some logistics around Beyfortus as well. But so the current CDC and AAP recommendations for Beyfortus are that it's recommended for all infants younger than 8 months of age who are born during or who are entering their first RSV season. And as Dr. Meyer talked about, that's unless their mother was vaccinated during pregnancy, and there will be some exceptions there as well. But additionally, it's recommended for some children aged 8 to 19 months who are at increased risk for severe RSV disease and entering their second RSV season. And Dr. Lee talked a bit about, would you go to the next slide, please? Or am I advancing the slides? Oh, perfect, thanks. Talked a bit about Synagis. And so the question is, are we done giving Synagis? So, you know, we used to, there's guidance from the AEP for the use of Synagis prophylaxis against RSV, which was first published in a policy statement in 1998. And part of the workflow in the NICU for many years and in other groups who work with high-risk infants has been that we, you know, each year we check the AAP recommendations, which are updated to reflect the most recent literature regarding children at greatest risk of RSV disease, of severe RSV disease. And typically, so those are infants born at less than or equal to 29 weeks gestational age. Or born between 29 and 32 weeks gestational age with additional risk factors, or infants who have congenital heart disease, and that is typically unrepaired and hemodynamically significant congenital heart disease, so not babies with a small VSD, or infants with severe immunosuppression, severe neuromuscular disease, severe pulmonary disease, or Down syndrome. And so what we have done in past years is we've administered during RSV season, we wait for RSV season to start. We identify these infants that are being discharged, and then we give the first dose of Synagis prior to discharge from the NICU. And then, as Dr. Lee mentioned, they get a monthly dose of Synagis through the rest of RSV season, either through home nursing or at their pediatrician's office. So the question of, are we done giving Synagis yet? I think we're close, but not yet. And that is because of the shortages. So Nirsevimab Beyfortus is not yet available. We don't have it available here up at UVMMC in our inpatient units, and that is due to the fact that we're not currently enrolled in VFC, although we're working on that. And also down the road, this may become less of an issue, but right now the maternal vaccine, we haven't seen many moms who have been vaccinated previously. So there are still infants who need RSV protection in this highest risk group. And so we want to make sure that we don't miss getting them that protection, even in light of the shortage. So the current workflow we've come up with in the NICU right now, and I'm hoping that we barely ever have to use this. Next slide, please. So this is just for this season. And again, hopefully we have more supply and then we don't have to do this often. But we're looking to see, does the infant meet the previous criteria for administration of Synagis? And then if they do, we are calling their pediatrician's office and trying to determine whether they'll be able to receive a dose of Beyfortus within a few days of discharge, and also if they're able to avoid sick contacts. And this is a bit arbitrary, the 5 days, but just the overall message is we don't want to send kids who would have been getting Synagis home to families who have other sick kids without a plan in place. We don't want to send them home to families with sick kids without giving them Synagis prior to discharge. And we also don't want to send them home without a plan, even if there aren't other sick contacts around. We want to make sure that we have a plan in place for them to get Beyfortus shortly after discharge. So if that's the case, we will send them home with that plan. And if not, they're still going to get Synagis prior to discharge. And then if they get Synagis prior to discharge, they can receive a dose of Beyfortus 30 days after the Synagis when it becomes available. And then if it's still not available, which again, hopefully is not the case, they'll continue to get Synagis every single month until Beyfortus is available or until RSV season ends. And then of course we have other high-risk infants discharging from the NICU that won't be Synagis eligible, and the plan for those patients and really for all babies is just for them to get a dose of Beyfortus as soon as possible after discharge. We've only discharged one infant so far this year that was Synagis eligible, and we were able to secure a dose of Beyfortus for them within a day or two after discharge. And so in light of the shortage, the recent recommendations are, and I know Katie's going to talk about this in a lot more detail, but so for infants 5 kilos and born before 5 kilos or less and born before October of this year, they're going to get a 50 milligram dose, or that's the recommendation. And I know there's a lot of work to do still as far as how to prioritize these, but again, hopefully those highest risk Synagis eligible infants will be able to get them. And then for larger infants, the priority is to give the 100 milligram Beyfortus doses to the infants at highest risk of severe disease, which is infants less than 6 months of age, American Indian and Alaska Native infants less than 8 months of age, infants age 6 to 8 months with conditions that put them at the highest risk of RSV disease. And then in the older Synagis eligible infants who are 8 to 19 months of age, they are no longer going to be getting Beyfortus, and those infants are also going to get Synagis per the AAP recommendations. And that's again because of the more significant shortage of the 100 milligram doses. So there are some specific instances where we'll continue to administer Synagis to eligible infants until we have enough Beyfortus. And I mentioned that plan that we have to communicate with pediatricians, with the PCPs prior to discharge to determine whether or not our highest risk infants will be able to get Beyfortus. When in doubt, those highest risk infants who qualify will get Synagis. And we're working on our VFC enrollment up here and hoping we can move that along as quickly as possible, and also working on providing information to families about Beyfortus, and that's particularly the families where they already missed the window to get the maternal vaccination. The mom didn't get it, and we're recommending it for all families. And then just waiting for those supplies to improve. And I'm hoping that all of this will just be much more simple next year when we have enough supply.
All right, thank you for having me. I'm Katie, and I'm a nurse with the immunization program. Next slide. I'm going to briefly talk about our program, what enrollment looks like for the program, and then the two different RSV products, specifically about availability and rollout. I put on the right-hand side there a lot of contact information. If you have questions after this, I am going to glaze through some of these slides, a lot of information, but if you have questions, please reach out. Next slide. So I want to start with talking about a quick overview of our program and how it works in Vermont. Next slide. So we have two programs. We have VFC and we have VFA, and the vaccine for children, vaccine for adults. Birthing hospitals can enroll in VFC and receive that birth Hep B dose and now the monoclonal antibody. And all OBGYN offices are also eligible to enroll in VFC and VFA to receive Tdap, flu, COVID, and now the RSV vaccine. Next slide. So each state across the country runs their immunization program differently. Vermont is what we call a universal vaccine state. And so what that means is we have a program called the Vermont Vaccine Purchasing Program, and that program collects funding from health insurers and adds that to the federal funding we receive and uses it to purchase vaccines from the CDC contract at a lower rate. All of that vaccine is then given to providers at no charge, and then they can administer it. This means that all children should be able to access vaccine at their primary care provider without the provider having to pay upfront for all of those vaccines. And just for some perspective, some of our larger pediatric offices have over $100,000 of vaccine in their refrigerator at any time. So this really not having to pay upfront is a big deal for our providers. We also have this program for adults, the VFA. This vaccine purchasing program works for VFA for adults 19 to 64 years, and it's not for 65 and up because Medicare will not pay in. Next slide. So I briefly want to cover what enrollment looks like because I'm going to be talking about our enrollment efforts and strategies, availability for those that are enrolled. Next slide. So these are the basic requirements to be able to join one or both of the programs. There's also a link for more in-depth requirements within that agreement and a contact to reach out for our VFC coordinator who's in charge of enrollment for VFC and VFA. The enrollment process can be as quick as a few weeks, but it usually takes longer just because organizations need to go through and develop internal policies, procedures, clear it through multiple levels. So it often does take a lot longer. After all of the paperwork is submitted, there is the culmination of a site visit. And then after that site visit, the organization can start ordering vaccine through VFC and VFA. Next slide. So I'm going to start with the monoclonal antibody product because I think the shortages or the limited availability is really setting up a lot of the conversation about recommendations for the RSV vaccine. Next slide. So this product is available through the VFC program. All enrolled offices can order as availability is there. So as soon as nirsevimab was approved by the CDC, the immunization program began outreach to birthing hospitals. We already had 2 birthing hospitals that were enrolled for that Hep B dose, and you can see now where we are with 5 enrolled hospitals and other hospitals in the terms of stage for enrollment. Next slide. I just want to recap that for the product, there are the 2 different doses based on age and weight for younger infants. So when providers they're asked to order X number of 50 milligram doses and X number of 100 milligram doses, and it's in multiples of 5. So just in terms of the ordering. Next slide. So I think by now everyone has heard that we don't have adequate supply of nirsevimab. I want to just recap here what happened. Ordering opened in VTrax, which is our online ordering system, on October 10th for birthing hospitals and October 11th for providers. We didn't have any birthing hospitals order. They weren't prepared to administer. So even if you're enrolled, there are other pieces that have to be in place to be able to administer. So for instance, programs often need to have billing and coding in place. So the product itself is provided for free, but there's still billing for the administration fee. They need to have it in their EHR to be able to track it. So that piece about building out modules and EHRs often can hold up. And this was a really quick rollout, even in terms of getting the codes from CDC for the products, like the CVX codes and things like that. So we didn't have any birthing hospitals order. CDC abruptly paused ordering on October 13th. We had no advance warning, and we had several large pediatric offices that did not have any orders in, or their orders were canceled by CDC. The orders that were submitted did start actually arriving the week of October 16th, and they've now all arrived in state. When they started coming in, we immediately reached out to providers and asked them to hold administration except for high-risk kiddos, so we could determine about reallocation. Next slide. So like I said, we immediately reached out and started thinking about reallocation. We worked with our data analysis team to review the data. We reached out to AAP, or the Vermont chapter of AAP and UVMC for some guidance as well and input. All of the nirsevimab product was redistributed the week of October 23rd. Doses were picked up from providers that had a larger amount. So what happened is we ended up redistributing among the larger pediatric offices that approximately serve about 85% of the population in the state, or the target population. Smaller offices that weren't within those group of providers that received product were informed that they could reach out to district offices who have a very limited supply. So 1 box, 5 doses of the 50 milligrams, 5 doses of the 100 milligrams to transfer for high-risk patients. And just putting in perspective, we received approximately 1,300 doses in the state. That's both 50 milligram and 100 milligram. And if you think about potentially 5,000 births in a year, we know those numbers just don't match up in terms of the amount of available. So we know supply is inadequate, and providers have to make difficult decisions about their patient panel on who to administer. We have the CDC HON recommendations, and we still don't have enough supply to meet those basic recommendations of, which I'll talk about in a little bit, but prioritizing those younger infants. So next slide. So these are these recommendations. I put a link here. Again, this first recommendation for the infants under 5 kilograms, the recommendations are unchanged. We don't have enough supply to follow that. And for the infants over 5 kilograms that need that 100 milligram dose, they are prioritizing, according to CDC, these 3 different populations: young infants under 6 months, American Indian and Alaskan Native infants, and then infants 6 to 8 months with those chronic conditions or conditions that put them at high risk of severe disease. Again, just want to reiterate, not enough supply. So providers are having to make difficult decisions. Next slide. I'm not going to go through all of these in detail because I have the link, and I think everyone really needs to read it for themselves. But you will see, as kind of alluded to earlier, there was a recommendation to suspend nirsevimab use in that second season children, except for those who are American Indian and Alaskan Native. And also that recommendation there on number 7 to really encourage pregnant people to receive the vaccine. Next slide. So we're asking ourselves, what's next in terms of supply? I don't have a crystal ball. I wish I did. So I'm gonna have to be honest and say we don't really know. What I can tell you is that CDC communications that we have received have not been clear about when ordering will resume. We've been told that some jurisdictions, so other immunization programs across the state, which every state has one, the territories, and then some larger cities have their own jurisdiction. Some did not place any orders, and some placed very limited orders compared to their overall population. So those jurisdictions are going to be prioritized as ordering resumes. Ordering actually has resumed for some of those at a very limited level. We have not been given the go-ahead to start ordering again. They're telling us that product will be available every 2 to 3 weeks, and they'll let us know when we can order again. We know we'll be under allocation when ordering resumes, so we'll be under limited supply. We can't just order whatever we want. And we really don't have a good idea about how many jurisdictions didn't place orders or had really limited orders. So we're not sure where we are in that list of getting to order again. When ordering reopens, our program has determined that the goal is to prioritize birthing hospitals that are prepared to administer that 50 milligram dose. Again, we don't know when that will be though, so we can't, but that's our goal, is to prioritize that group. Sanofi, which is the manufacturer, has indicated that for private supply orders, which kind of helps us show what the landscape is overall, that those are also back ordered until December or January. And we've also been hearing that from jurisdictions that don't have universal purchase systems, that they're hearing from the providers that orders are back ordered until early 2024. So CDC and Sanofi have both indicated that there's less availability for that 100 milligram dose, which I think is reinforced in those recommendations by CDC and the HON to stop use for the second season, and thinking about prioritizing those younger kids, which again, still not the supply to even do that. So next slide. So knowing that availability of nirsevimab is very limited and we don't know exactly when it will resume and what that will look like, I want to move to Abrysvo, which is the vaccine for pregnant individuals. Next slide. So I want to start with sharing this infographic from CDC about the vaccine process. I put some information on the right-hand side about steps that happen after that dark blue part, where ACIP approves and makes a recommendation. If when I created this slide yesterday, I could have made a big "We Are Here" sign, I would have put it at this dark bullet at the bottom. We're waiting for the CDC to make it available on the contracts so we can open up ordering and start distributing. Since I submitted these slides this morning at 9:45, we got an email that the vaccine has been put on the adult price list, which is a first step. So I immediately reached out to my colleagues that have more ordering experience than I do and said, what does this mean? Can you give me a timeline? I'm going to be talking this afternoon. I'd love to say. And I got 3 different answers. One was soonish. One was maybe 2 weeks. And then the one I would say has had the most experience in our program said, well, we usually need at least a month. When they start putting it on there, we have to submit what's called our spend plan, which means we tell CDC how much we want to order of each type of vaccine and how much money. And they ask for that a month in advance. So they're just now getting out the November. So her thought was more in December 1st availability potentially for the vaccine through VFC. But she said also that the things have been pretty wonky for RSV and even COVID recently compared to her years and years of experience. So maybe they'll do something out of cycle and change things up. So again, we don't know. Next slide. Again, once it's available on contract, we can put it in people's to order in VTRAPS, our online ordering system. We're conducting outreach to OBGYNs to assess interest in enrolling. These are the ones that are currently enrolled that I have listed here. If you're with an OBGYN program, you don't see your name here, and you want to enroll, please reach out using the slides I have there with the contact information earlier. And we would be happy to talk about that process with you. Next slide. So in terms of our immunization program plan for Abrysvo, We think it will likely be under allocation when it's first available to order, which again means limited ordering, that we can't just go in and order whatever we want. Hopefully it's not super limited, but we're just putting out there, we think that. We don't have a date again. We are talking internally about what strategies we might be able to use to prioritize providers that serve pregnant individuals. So both the Brisbo vaccine and the RSV, which is the other RSV vaccine, popped up on that vaccine adult list. A RSV is approved for 60 years plus. A Brisbo is approved for pregnant individuals and 60 years plus. So with our Vermont adult vaccine program, providers can order for that 60 to 64 years, that RSV vaccine, when it's available for ordering. So we're talking about, are there ways that we could only allow them to order a RSV if they don't see pregnant individuals, which is a little complicated because family providers might also see pregnant individuals, but thinking about strategies for how we might look at that. OBGYNs can private purchase, but as we discussed earlier, it can be a lot of money up front to order all this vaccine, especially if you don't know the demand. Next slide. So since I feel like there wasn't super great news about a timeline, I wanted to talk a little bit about what we think access looks like at pharmacies. We've reached out to some of our state partners, pharmacy partners, and feedback we've received is that individual pharmacies are approaching this differently. Walgreens online scheduler does allow you to schedule for an RSV vaccine as a pregnant individual. CVS doesn't. We don't know if that's because CVS isn't carrying a Brisbo and they're only carrying a RSV, which they couldn't administer to a pregnant individual, or because they want people to schedule in a different manner. We've heard anecdotally of individuals, one or two individuals that had a prescription that were turned away from pharmacy. So they had the prescription from the provider and still were not able to access it. Kenny Drugs is not offering this vaccine for pregnant individuals, but DIVA Pharmacy Unit is one of the groups we reached out to who kindly offered to act as a liaison. And I put this in the box. If you were an OBGYN writer and you're having trouble finding a pharmacy to refer to, and you have a Kenny Drugs near you, Kenny Drugs is open to collaborating on a vaccine clinic or some kind of controlled single store setting to allow shared decision making. This isn't a shared decision making authorization from ACIP, but we are hearing that there are potentially some pharmacy concerns due to the package insert about preterm birth and preeclampsia. And then the other thing I just wanted to share from our Medicaid partners is that for individuals that have Medicaid, if they're under 60, which would be our pregnant individuals, no one else under 60 should be getting this vaccine according to how it's licensed and authorized by ACIP. But under 60, a prior authorization will be needed from the prescriber to go to receive this vaccine at pharmacy. And next slide. And that's all I have, but that's what I can tell you about rollout and availability.
Thanks, Kitty. I'm just going to go ahead and ask real quick. Can you, that last point, I just want to I want to understand it better. Does that mean that a pregnant person going into a pharmacy needs to have a prior auth before getting the vaccine there? Like, can you just walk me through? If somebody's like, I want to go get it, what has to happen?
So this is from Medicaid, so I can't talk about like privately insured people, and honestly privately insured companies have up to a year to cover vaccines according to Affordable Care Act that are ACIP recommended. So if you have a privately insured person, I would really recommend making sure that it's covered through their insurance if you're referring them to a pharmacy or that they can afford to pay out of pocket. But for Medicaid, there is a prior authorization process, and there's some forms that need to be filled out, and I can send those links that they sent me, because I also asked, I said, what does that mean? So yes.
So that means that we fill out a prior auth form. How does the pharmacy know that that form is done? Do they just look it up? How does that work?
It's a great question, and I will have to ask the DIVA Pharmacy Unit about that question and follow back up with you.
Okay. And yeah, Andrea, on one of my slides, there are 2 slides, one for the provider scripting, and then the other one is going to be for the parents, for the patient, but I didn't put in there anything about these specifics about how to get it or prior auths or cost, because I had no idea about any of that.
All right, so I see a question in the chat of, is there a vaccine information sheet available to provide parents or patients? And I believe the answer is it's in progress. I believe Marge and Ben can speak a little bit more about that.
Yeah, as far as
Yeah.
I'm concerned, you can use the one, and Sam, you can send it around or even post it in here, just those 2. Again, one is super wordy for the provider script. The other is just for the patients. They're not branded because they're like still in our branding office, but so many people were asking us about this. I was like, oh, for goodness sake, just use them. And you can figure out how to brand them in your institution. So Sam, just email Sam if you can't pull it up from the chat.
And I'm not sure if the question was about like a CDC VIS sheet. If that is the case, I just checked, CDC does have a VIS now up for the RSV vaccines dated as of October 19th, 2023. There is a version that, yeah, the immunization information sheet.
Yeah, Katie,
So
this
if
is
that
Brina.
was the question, that is available now.
Yeah, Katie, you have that available, right? That's the VIS is what I think Andrea is asking for. So, because that's keeps the information standardized across the state. So let's get that into the hands of the folks on the call. Oh, there it is. Magic. So just in case this is a different audience than the COVID calls we did continue to do with the Scoop call, I have this role as chat human. So I just, in case, sometimes we find people on webinars are not accessing the chat. So I wanted to make sure folks knew that Ben has put the VIS CDC information in the chat, which we can get out to you at the exact same moment that Katie was linking it. That's a rare event in a chat. I also wanted to call out, because when Katie was talking, I put in a chat that before I worked at the health department, I had no idea how comprehensive and awesome it was to have a vaccines for children and now a vaccines for adult program. So in case you're digesting national news about RSV shot, which is what we're calling it, to Ben's point, it's not a vaccine, just make sure you check with the Vermont story, because there isn't a cost associated. It's all paid for through this cool thing, vaccines for children, and the adult part is even more rare in this country. So just great public policy and health department engagement in this space.
It is, but it sounds like your provider needs to be in this program to do it. I still, it's not like they can go to the pharmacy. I'm making sure I understand this correctly. They can't go to the pharmacy and get it for free. Is that right?
It depends on your insurance coverage. So it is, so for adults, Medicaid will cover vaccines at pharmacies. There is this product is different. This monoclonal antibody product is different because it's not being offered in pharmacies. But just for context, like for children, Medicaid does not cover the cost of vaccines in pharmacy. They only cover the cost for places that are enrolled in VFC. And also, actually, there's state legislation that pharmacies can only vaccinate 5 and up for flu and COVID. But for adults trying to access this RSV vaccine, it will be covered through Medicaid, as we've been told. And then for private insurers, we're really recommending that they call the private insurance company and make sure that they've put it on their coverage so far, because they have, according to Affordable Care Act, they have up to a year to actually cover it after ACIP recommendation. And I'll just add to you, for the price list that came up this morning, CDC is quoting a private purchase price for a Brisboa of $295 a dose. So if someone's insurance doesn't cover it, that would be, within that ballpark of how much it would be.
Are there any other questions?
I see a question from Steve in the chat about would there need to be a PA before giving, and I honestly need to get back to you on that. Bullying and coding is usually not our area of expertise, and so I did an outreach to partners to try and get some better ideas, and the information they gave me is something I'm unfamiliar with. So I will have to ask if that's only for pharmacies that have the prior authorization requirement, or if that's across the board. The terminology was the Vermont Drug Utilization Board approved it. So the excerpt I got didn't clearly state what about location, but I was asking specifically about pharmacy. So I need to double check and get back to you guys.
Thanks, Katie. I would give it a high percentage chance that you don't need a prior auth in an office setting, based on what you just said with drug utilization review. Folks, I wanted to make sure you knew too, this is a really cool collaborative team. Look what you got here, right? You got the health department, you got infectious disease, awesome Ben, you've got Marge, and you've got Whitney. So we should keep the questions coming, because I think we're in a, we got really organized about this briefly and then realized there wasn't enough supply. So now we have a chance to, in the absence of supply, to get even more organized, especially with the hospitals enrolling in the Vaccines for Children program, which just making sure everyone heard that that's not on Katie. The health department is not the holdup in the paperwork. It's the internal processes in hospitals to get the darn thing done. So there's been a little confusion about that. So if you're out there in hospital land, it would be great to have you figure out your process if you aren't on that list Katie's supplied about those in process or that have been approved.
All right, so it looks like we're right at time. So if anybody has additional questions, I've put up the slide with everybody's contact information, or you can just email me directly, or respond to the email I'll be sending out tomorrow as a follow-up, and I'll direct your question as needed. So you all know you all will be receiving an email tomorrow with the recording link as well as the slides, and a short evaluation survey. So thank you all for attending. I really appreciate you guys being here.
Honestly, Katie,